So let me introduce the next speaker. Next speaker is Dr. Arundhati Agarwal Kelkar. She's an oncopathologist in Jaipur at the STMH and Precision Lab. And she's going to tell us about the next issue, which is that if imaging and tumor marker is not giving us the definite diagnosis of a liver space occupying lesion, what is the role of getting a tissue diagnosis? Dr. Arundhati.
At the outset, sir, let me thank you for giving this opportunity to have a discussion with this esteemed group. I'll begin on a very humble note since, radiology is the mainstay for diagnosis of most liver masses, whether they are cystic or solid, benign or malignant. And it's only a few cases that trickle down to a pathologist for tissue diagnosis. So there are cases where radiology does not allow precise characterization of the tumor, and this is where a pathologist's role comes into picture. Also, with the increasing use of personalized targeted molecular studies, tumor tissue is often required for molecular characterization, and that's where biopsies are usually done. So the modalities that are used for pathologic diagnosis are FNACs with or without cell blocks, core needle biopsies, and other ancillary studies like some special stains and immunohistochemistry. So FNACs are, as all of us know, it's an accurate, very rapid and safe procedure for tissue diagnosis with sensitivity and specificity of nearly 100% for detection of liver malignancies. The main indication remains diagnosis of focal mass lesions for confirming malignancy, differentiating between primary and secondary malignancies, and in some cases, differentiating between benign and malignant hepatocytic conditions. Complications are rare, with very few contraindications that include a refractory bleeding diathesis, massive ascites, and uncooperative patients. So just to give you an insight on what we see in FNAC smears. So of course, the hepatocytes, which appear as polygonal cells with abundant cytoplasm, fairly round regular nuclei with tiny nucleoli. We see bile duct cells that appear as a honeycomb sheet of cuboidal cells. We tend to see a lot of endothelial cells that appear as spindle-shaped cells stretched out as capillaries, and certain other cells, very rarely, like Kupffer cells, which are not so usual in FNACs. So different conditions can cause an increase or decrease in the number of cells that we see on the smears. So hepatocytes, again, in benign as well as malignant conditions, bile duct cells in intrahepatic cholangiocarcinomas, bile duct cystadenomas, endothelial cells in hemangioendotheliomas as well as angiosarcomas. So the diagnostic criteria for hepatocellular carcinomas are basically hypercellular smears with clusters of hepatocytes that are arranged as arborizing tongues that are more than 2 cells thick. We often see rows of transgressing endothelial cells with pseudoacini formation. Usually, well-differentiated hepatocellular carcinomas have smaller sized cells that are more monotonous. We often get to see naked nuclei in poorly differentiated hepatocellular carcinomas with marked pleomorphism. So this is a slide that shows a smear and a corresponding biopsy section of well-differentiated hepatocellular carcinoma, which shows thick arborizing cords of malignant hepatocytes that are fairly monotonous, with the spaces that you see in between are the pseudoacini. If we move on to a higher grade of differentiation, like in a moderately differentiated hepatocellular carcinomas, we see that the trabeculae are much thicker as compared to what we saw in a well-differentiated hepatocellular carcinoma. And these very typical capillary envelopes that you see surrounding the trabeculae, there are lots of transgressing capillaries traversing in between the trabeculae. As we move towards the higher spectrum, this is a poorly differentiated hepatocellular carcinoma with a lot of nuclear pleomorphism, a lot of bare nuclei, very irregular nuclear outlines, and if we can see those huge, very prominent cherry red kind of macronucleoli. So this is just a combined slide of the three grades of differentiation with their corresponding histopathology. So when it comes to FNACs, problems arise at the ends of the spectrum, that is the well-differentiated and the poorly differentiated hepatocellular carcinomas. If you see the image of this is a focal nodular hyperplasia where you have bland appearing hepatocytes that form very loose sheets or clusters. And this lesion is virtually impossible to differentiate from a well-differentiated hepatocellular carcinoma on FNAC because the features are practically the same in both of these lesions. Again, a regenerative nodule shows essentially the same features like a well-differentiated hepatocellular carcinoma, making it nearly impossible to differentiate the two lesions on FNAC. If we come to the other end of the spectrum, a poorly differentiated hepatocellular carcinoma is sometimes impossible to differentiate from a metastatic tumor, not only a metastatic carcinoma, but sometimes even melanomas or GISTs for that matter. So the diagnostic dilemmas of a well-differentiated nodular hepatocytic lesion, there are a couple of things that come into mind. Is the sample representative of the lesion? Are the hepatocytes malignant or are they benign? If they are benign, are they neoplastic? As in, do they represent an adenoma or are they non-neoplastic hepatocytes? And if non-neoplastic, are they from within the lesion or are they extra-lesional? Grade 1 HCCs, like I said, they are very difficult to differentiate from benign regenerative nodules, FNH, as well as adenomas, because they show minimal nuclear pleomorphism and have abundant cytoplasm. Grade 4, that is the poorly differentiated HCCs, they may be difficult to differentiate from high-grade tumors of non-hepatocellular origin. And that is why architectural features are actually the best clue to the diagnosis, which include trabecular pattern, prominent vascular pattern, among other features. So differentiation at both ends of the spectrum is what is problematic in FNACs. And that is why a combined cytologic and histopathologic approach is recommended in liver lesions. So one of the modalities for a histologic or a combined approach is cell block preparation. So wherever diagnosis by FNACs is equivocal, it is recommended to perform a cell block along with the FNA, because this gives us tissue material to not only study the architecture, but also gives us material for carrying out ancillary studies like special stains or immunohistochemistry, and also providing tissue for further testing if required. So just a small technical appraise of how tissue blocks or cell blocks are made. After the smears are prepared, the residual clot or tissue in the needle is removed and fixed in formalin. Minimum fixation time that is recommended is 4 hours in neutral buffered formalin. So, and then it is processed as a routine biopsy specimen. So just a pictorial slide for what a tissue block or a cell block looks like. The upper image is that of a cell block. If you can see, it's giving a very good representation of the architecture, and this tissue can be used for carrying out further tests. So when combined with a cell block, an FNAC gives very high specificity to the tune of nearly 100%. So it's recommended that a cell block be done along with FNACs. So in spite of having biopsy material or tissue blocks along with FNACs, sometimes a definitive pathologic diagnosis cannot be obtained by a histologic evaluation alone. And this is where immunohistochemistry plays an invaluable role. This material can also be used for molecular testing. Immunohistochemistry also occasionally reflects specific genetic mutations. So the markers that are most commonly used in practice are one set of markers of hepatocellular differentiation, which includes hepatocyte paraffin 1 or HEPAR1, arginase 1, and polyclonal CEA. And then there is a set of markers for malignant hepatocytes that includes glypican 3, heat shock protein 70, as well as glutamine synthetase. So this is a representation of HEPAR1. As you can see, it's a granular cytoplasmic expression and very sensitive in lower grade tumors or better differentiated tumors. And it has a poor sensitivity in serous HCCs as well as poorly differentiated HCCs. Arginase 1 is by far the most sensitive marker of HCC with a very high sensitivity even in poorly differentiated HCCs. Polyclonal CEA, again, it's a little difficult to interpret. As you can see, the staining pattern is entirely canalicular. So it's not really preferred by pathologists if you compare it with the other two markers. Glypican is a blessing of a marker because it gives positive staining in nearly 80 to 90% of HCCs while remaining negative in normal liver, in hepatocellular adenomas, focal nodular hyperplasias, as well as regenerative nodules. It has a low sensitivity in well-differentiated hepatocellular carcinomas and a better sensitivity in moderate or poorly differentiated tumors. HSP, the staining is usually patchy. It's not expressed in hepatocellular adenomas, but it does have a disadvantage that it is not useful in differentiating hepatocellular from non-hepatocellular neoplasms because it's quite often expressed in ICCs as well as metastatic tumors. Glutamine synthetase, again, is in a normal liver, it is confined in the 2 or 3 cell-thick hepatocytes around the central veins. It has a positivity of nearly 80% in low-grade hepatocellular carcinomas, while also being expressed in focal nodular hyperplasia and certain hepatocellular adenomas. CD34 is used as an indirect marker for evidence of arterialization in hepatocellular carcinomas. So in this slide, if you can see, at the lower right is the normal liver parenchyma, whereas as you move towards the upper left corner, you see the increasing arterialization with diffuse expression of CD34 by the endothelial cells. A few pointers in serous hepatocellular carcinomas. Glypican and arginase have a slightly lower sensitivity, whereas immunohistochemical staining for glypican is slightly better than HEPAR1 or polyclonal CEA. So these markers are preferred in serous variants. In fibrolamellar variants, it's a point to note is that almost all cases express CK7 and CD68. CK7 is usually negative in the conventional hepatocellular carcinomas. So now that we've spoken about the IHC markers that are useful in differentiating benign hepatocytic lesions from the malignant ones, this is a pictorial image of a focal nodular hyperplasia where you see a very patchy map-like staining of glutamine synthetase, whereas glypican-3 will be negative in this condition. So this is a useful combination to differentiate it from a tumor. In adenomas, depending on the subtypes of adenomas, various IHC markers, including beta-catenin or serum amyloid A, can be used for diagnosis. This is a classical membranous staining pattern of beta-catenin in the HNF1A inactivated hepatocellular hepatic adenomas. Serum amyloid A expression in the inflammation-associated adenomas. Apart from hepatocytic tumors, I'll just speak a little bit about the intrahepatic cholangiocarcinomas. The morphology is definitely different from hepatocellular carcinomas. We see more of a tubulopapillary sort of an architecture. And the IHC markers that are useful here are CK7, CK19, as well as TEA. A large spectrum of metastatic tumors in the liver, again showing either a nesting or acinar or sheet-like pattern. Sometimes it becomes very difficult to differentiate these from poorly differentiated HCCs, and that is where IHC again comes to the rescue with use of tissue-specific markers that includes CDX2 or synaptophysin or MUC5, sometimes GATA3, GCDFP, and TTF1. These are some of the markers that we used in metastatic settings. So in majority of the cases, it's the clinical information, the imaging, the tumor marker assessment that helps in diagnosing hepatocellular masses. And it remains challenging to diagnose hepatocellular carcinoma using only FNACs or only needle core biopsies. And using immunohistochemistry is invaluable in these conditions at both ends of the spectrum, where it's a very perplexing situation to differentiate between malignant, non-malignant, whether hepatocellular or non-hepatocellular. So with that, I end my presentation.
Thank you. I will just ask a very basic question before Dr. Saraswat takes over. For us, the surgeons, please just once again explain the differences between FNAC, FNB, and cell block, and do we need different sizes of needles for them? And are there any other differences?
So fine needle aspiration cytology is usually done with 23 gauge needle.
Apple ka service center ke nahi dekh lena babu.
Yes.
Yeah. It's usually preferable to do it with a 23 or a 24 gauge needle. It yields a good amount of material with minimal hemorrhage. So cytology is just preparation of the smears. What we use, the material that we still have with us after preparation of the smears can be used to prepare cell blocks. Whereas biopsies, again, you use a slightly wider bore needle for FNABs, and it's as good as a biopsy.
But when we say biopsy, needle biopsy, core needle biopsy, we use the conventional needle where we get a core of tissue. So is there a difference between a core needle biopsy and a fine needle aspiration biopsy?
Yes. So the difference is in the bore of the needle, and also that the tissue particles that we obtain on doing an FNAC, those tissue particles can be used directly as a biopsy representation. So that is what we call it as an FNAB.
So this new technique of cell block, because many a time intraoperatively, we the surgeons ourselves take an FNAC. But to prepare a cell block, we will have to seek your help, isn't it?
Not really, sir, because once you've aspirated a lesion, if you make smears intraoperatively, you can just aspirate formalin into the same syringe, and by which the tissue that is left in the, or the material that's left in the hub of the needle gets fixed, and this can be centrifuged and then further processed as a routine biopsy. So you don't need a pathologist's help to make a cell block per se.
Right. I think, in fact, all the endosonologists and the IR people, when they do their FNACs, they make their own cell blocks and get them assessed. Dr. Arundhati, I must compliment you on an excellent presentation, a very thorough and elaborate presentation, which gave us a clear idea of histopathology. However, I think the thing is, we are talking about a tumor where almost all guidelines are agreed that one imaging, or if in doubt, two imaging modalities suffice to make the diagnosis, and it's a very small minority, maybe less than 5%, where the pathologist has a role. I think something that you mentioned right in the beginning of your presentation. So just to recap, I think the situations where what information we are seeking from the pathologist is, one is diagnostic, particularly differentiation between benign and malignant lesions. The second, you elaborated about the degree of differentiation, well differentiated, moderately, and poorly differentiated. Then maybe I think the bit about personalized therapy got kind of, you didn't touch upon that, possibly time constraints, but identifying predictors of aggressive behavior at the cellular level using your various IHC techniques that you showed us so well. And finally, this choice of personalized therapy I briefly mentioned. I think here and in most parts of our country, what we are seeing are advanced tumors. Our surgical colleagues are basically talking of early tumors which are amenable to resection or to transplant, whereas a very large number, as in most cancers, come to us as advanced tumors, and they're choosing personalized therapy. Which person will show a response to immunotherapy or not is something that is work in progress, but probably that is where the pathologist will have a significant role, like identifying the hot tumors with a lot of cytotoxic T cells. So I hope I've got that correct. And tell me today, how does a degree of differentiation knowledge help me to plan treatment? Because if the loco-regional ablative therapies, regardless of the degree of differentiation, will get ablated. And chemotherapy, where generally differentiation used to play a role, doesn't seem to have much of a role in the treatment of HCC. You talk about multi-tyrosine kinase inhibitors or immunotherapy modalities for therapy. So if I get from the pathologist this knowledge about degree of differentiation, will it help me in choice of therapy for HCC?
I think one of the clinical colleagues will have to answer this. Differentiation given by a pathologist, does it make a difference in therapy?
Right. Well, I think in most, when you are surgically or doing it or you're ablating it, it doesn't really matter. But with advanced tumors, as we know, all these immunotherapy modalities are extremely expensive. And in case you're able to identify the 10% of prospective complete responders with the immunotherapy, or the 30% of at least partial responders, it would help in confining the therapy to these patients. So that is where the personalization would come in, and that might help. Right. Any other rules other than what I mentioned? And maybe other panelists moderators can come in with their comments.
Biju, Raj, Bala, anything you would like to add on the role of the exact details of histopathology as far as the treatment is concerned, choice of treatment?
Yeah, so when the final biopsy comes in as hepatocellular carcinoma and we ask for IHC staining, actually quite a few times we find that there is a cholangio component which is detected on IHC staining. So that actually changes the management post-op, and that actually tells us that patient is going to have a different prognosis. So it's always better to ask for an IHC staining after you have received the histopathology report.
So you're talking, Bala, this is a preoperative biopsy or the
No, I'm
explant of
talking
the
of
resected liver?
no, sir. I'm talking of during transplant the hepatectomy specimen.
No, but Bala, suppose for whatever reason we have done a preoperative biopsy because the imaging and markers did not help. We confirm the diagnosis of CC. Is the degree of differentiation going to decide whether you are going to resect, whether you are going to transplant?
The degree of differentiation will not make any difference. Only thing is if it comes as cholangio, transplant is off.
It's a different disease.
Okay.
Yeah, so that's important.
HCC, sir, HCC differentiation is not like a stomach cancer or other thing. This differentiation and the biological aggressions is not exactly correlated with that. That's why we don't use it so extensively for a pre-op planning, except the situation where Dr. Bala has told. Yeah.
Okay.
Actually, the role of biopsy is very limited, as Dr. Saraswat was saying.
Yeah.
It's only for a small part of LR3 lesions.
Yes.
Which is actually a very small number.
Okay, so I think anything else, Dr. Saraswat, you want to add? 1 minute we have.
Actually,
really, I think I just have to say that we had a very nice and a very educative presentation. There are a lot of names and terms of IHC markers, etc., that we have read, but we don't know what it looks like. So we have to thank Dr. Agarwal for familiarizing us with these. If anybody else has any other comments, please.
Thank you, Arundhati. Thank you very much for contributing. And as Dr. Saraswat commented, for an excellent presentation. I hope to see you in future sessions of Jaipur Surgical Tutorial.
Definitely,
also.
sir. Thank you.
So with that dot on time, we move on to the third presentation of the session.